All right, let's jump right in. Today we're breaking down acute respiratory alkalosis. It's a really high-yield acid-base disorder that, trust me, you're going to see everywhere, from the emergency department dealing with sepsis to a patient having a panic attack. We're going to make this super simple and clear. So picture this. You've got a patient who comes in, they're suddenly short of breath, they're feeling dizzy. What's going on? Is this just a panic attack, or could it be a life-threatening pulmonary embolism? This is where understanding respiratory alkalosis becomes absolutely critical, because it's key to telling the difference. So what's really going on under the hood? Well, at its core, you can think of this condition as the body just overreacting. It's a response to some other trigger that's setting it off. Okay, so what is it? Simply put, it's what happens when a sudden increase in breathing, we're talking faster or deeper breaths, makes you blow off way too much carbon dioxide, or CO2. And the basic chemistry here is really the key. See, CO2 forms carbonic acid in your blood. So it's simple, right? Less CO2 means less acid. And that makes your blood pH shoot up, becoming alkaline. You can think of it like a really simple but powerful three-step chain reaction. First, something makes your respiratory drive just kick into overdrive. Second, as you start hyperventilating, your CO2 levels just plummet. And third, with less of that acid-forming CO2 around, your blood pH starts to climb. Boom, 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 a direct cause and effect. Okay, so how is this actually going to look in a patient sitting in front of you? Let's talk about the clinical clues, the signs and symptoms that should make you think, could this be it? A lot of times, patients will talk about this feeling of air hunger, that classic sensation where they just can't get a deep, satisfying breath. They'll often mention numbness, especially right around their mouth, or that pins and needles tingling in their fingers and toes. But, and this is super important, sometimes the hyperventilation is really subtle. You might not even notice it on your exam. And get this, some patients might be completely asymptomatic. So, if the symptoms can be a little tricky or even absent, how do we actually prove it? Well, this is where the lab work comes in. We've got to decode the arterial blood gas, the good old ABG. The ABG is what's going to give you that definitive proof. And really, you're looking for just two key numbers. First, a PCO₂. That's the partial pressure of carbon dioxide in the blood. You're looking for a low number, less than 35. And second, as a result, you'll see a high pH, something alkaline, over 750. You see those two together? That pretty much clinches the diagnosis. Now, here's a key point. Because we're talking about an acute process, something that's happening right now, the body's main long-term compensator, the kidneys, they just haven't had time to react yet. They haven't had a chance to adjust the bicarbonate levels. And that's a huge clue that helps us separate this from a more chronic condition. So, this brings up a really important clinical question. Is the body's response what we'd expect for a simple, straightforward respiratory alkalosis? Or is there something else going on? Something more complex? And guess what? There's actually a way to figure that out. We can predict what the bicarbonate level, the main buffer in the blood, should be using a pretty simple formula. You just start with a baseline bicarb of 24, and then for every single point the PCO₂ has dropped below 40, you subtract 0.2. Now, if you do that math, and the patient's actual bicarb is way off from that expected number, well, that's a huge red flag. You should immediately start thinking about a more complex, mixed acid-base disorder. Okay, this leads us to what is arguably the most important part of this whole thing, hunting for the underlying cause. You've got to remember, the alkalosis itself, it's just a signpost. It's not the destination. It's pointing you towards the real problem. We can kind of group the causes into a few buckets to make it easier. First up, anything that tricks the body into thinking it's starved for oxygen. This is going to trigger that hyperventilation response. We're talking about things like being at high altitude, having severe anemia, or lung issues like pneumonia and congestive heart failure. And of course, the big one, the classic cause you always have to keep on your radar, is a pulmonary embolism. But the cause isn't always in the lungs. You've got systemic illnesses like sepsis that can just crank up the ventilation rate. Then you've got central nervous system problems. Think a stroke or a brain infection that can directly poke the brain's respiratory center and tell it to go, go, go. And we can't forget about drugs. The absolute textbook example is an aspirin overdose, which classically causes a respiratory alkalosis early on. But if we step outside the hospital walls, the single most common culprit you're going to run into, it's anxiety hyperventilation syndrome. Yeah, this is that classic panic attack scenario that sends people to the ER or their doctor's office. All right, so how do we manage all this?
The entire playbook honestly boils down to one single core principle. Treat the patient and the underlying cause, not the number you see on the lab report.
Your number one job, first and foremost, is to figure out why this person is hyperventilating. Is it a PE? Is it sepsis? Is it pain? Is it a panic attack? Once you nail down and treat that root cause, guess what? The respiratory alkalosis will fix itself. Now, for those cases where you're pretty sure it's anxiety-induced, you've probably heard of the whole paper bag trick, right? Using a rebreathing device. The idea behind it is simple. By having them rebreathe their own exhaled CO2, you can help raise their blood CO2 levels back up and relieve those neurologic symptoms like the tingling and dizziness. But, and this is a big but, you have to be so careful. This comes with a major warning. And this is a safety warning you absolutely cannot forget. Never, ever use a rebreathing device if there's even a tiny chance the patient is hyperventilating because of low oxygen or some other metabolic issue. I mean, think about it. If you mistakenly give a paper bag to someone who actually has a pulmonary embolism, you could make their low oxygen levels dangerously worse. You have to be 100% certain of the diagnosis first. So we've gone through all of this, the what it is, the diagnosis, the management. What's the one single thing, the most important takeaway that you need to walk away with? It's this right here. The alkalosis is the signal. It is not the disease. It's a vital clue, like a flashing red light that's telling you something else is wrong. And your job is to follow that clue and fix the real underlying problem.